A very good afternoon. This is Dr. Hiral Parikh. I am heading the department in periodontology, Narsibhai Patel Dental College and Hospital, Sakarthun Patel University. On this e-Vidya forum, today I am going to take a session on the most favorite topic of dentistry, that is basics of dental implantology. So let us start with the session. A small video will give you idea. This is a video, ancient video showcasing Parvati ji, Ganpati ji and Mahadev ji. It is a story where it says that due to some issues, Ganpati had a fight with Shiva. He was not aware, and then Shiva, what did he do? He just removed the head of Ganpati. But then he went to his mother Parvati ji and came to know that he was your son, oh our son. So he was in trouble, and finally he implanted the head of an elephant into Ganpati's head, and that was the first ever history of implant in our ancient literature. With this, I'll start today's session. What are the options available for replacement of tooth? You must be knowing it. Fixed partial denture, removable partial denture, and implants. Veneers, there are many options, but dental implant being the most suitable one. Do you have any idea about possible and common complications related to dental implants? Yes, it can be peri-implant mucositis, it can be peri-implantitis, it can be crestal bone loss, it can be a failure due to vicinity to the vital structure, and finally it ends up in disaster. So is it that simple that you go for some course, you take the lecture, you can have the presentation and you can put the implant? No, it is not a cakewalk. It requires meticulous idea. So if you fail to plan, you are bound to fail. And that is why in case of implant, retrospective planning is important. When I say retrospective planning, it means prosthetic planning. Patient wants tooth, not implant. So whenever patient requires the implant, you need to think about the prosthetic outcome of the implant. So the planning comes from the last thing, that is called retrospective planning. And that is how, keeping in mind many factors like bone density, bone height, bone volume, available crown height space, dimension of the area available, migration of the adjacent tooth, many things comes in the picture when you are planning for dental implant. And that is why they say the planning may take months, though the procedure may take hours. These are the contents of the implant. So basically, what is the implant? It is any substance which replaces the edentulous space. It is a substance which should be bioacceptable. That is why most of the implants are titanium coated. Titanium is a noble biomaterial. We can have it in the close interface with the bone, and that is where the principles of osseointegration comes into the picture. The causes of tooth loss can be caries, can be periodontitis, can be trauma. Periodontitis cases basically are not the very good cases or substitute for implant, because periodontitis is a basically common infection. So if you don't treat periodontitis, you should not opt for implant. First and foremost thing is to treat a periodontitis. Same way parafunctional habits. Now what does an implant do? See, once you put an implant, it is mandatory to have good union of that implant surface with the surrounding bone. It is basically an artificial root. We need to have a strong root which can bear the masticating load. And that is why after putting an implant, the close interface of implant and bone and close connection is required. This close connection terminology is known as osseointegration, means integration with the osseo, that is bone. This is the basic difference between implant and tooth. There is no periodontal ligament space when there is implant. You can see there is no periodontal ligament space. The bone is directly connected to implant, whereas in natural tooth there is a space that occupied by periodontal ligament, which bears the fibers of periodontal ligament. It bears the masticatory load very well, and that is why the planning of the implant is important. Otherwise the load distribution won't be good, and you will end up in disastrous result like fracture of tooth, abutment, fracture of implant, or fracture of bone. What are the indications? Of course, you all know trauma, recurrent soreness, unrealistic prosthetic expectation. These are the things which are indications, whereas there are two types of contraindication, absolute and relative. These are the absolute contraindication where you should not opt for implantology, and these are the relative contraindication, giving me to the consideration that you control these factors, you can definitely put an implant. Now, plannings. When we say implant planning, pre-treatment evaluation is must. Pre-treatment, we will have to consider first the chief complaint. What does patient want? That is important. Patient has come for X treatment and you are opting for Y treatment, that is implant. No. The patient should be zealous about placement of implant and replacement of tooth. Second, medical history. Medical history, how is it important? We'll learn later on. And third thing is significant dental history. Now, chief complaint. We need to think on these three lines: function, aesthetic, hygiene. When patient says that I am not able to chew because of edentulous space, I am not able to chew because of the mobile teeth, when I am not looking good because of this problem in anterior teeth, then understand the primary goal of the patient and then plan the treatment accordingly. History of present illness, whether some bone condition is there, whether some systemic condition is there, so systemic evaluation is must. Medical evaluation must be as the commonest disease, that is diabetes, hypertension, thyroid, some significant acute allergy, some history of viral diseases. Some analysis are required, blood investigation like CBC, then HbA1c assay, chest X-ray, ECG if patient is a known cardiac patient. So systemic factors you need to rule out. Then comes extraoral. When extraoral, it is smile line. If it is a cosmetic concern, an edentulous space in the anterior area, like the one which is seen in the photo, we want to see what is the smile line, where is the zenith of the other tooth lies. So you have to plan the implant and processes in such a way that the line, color of the implant metal should not be visible post procedure. So our final outcome should reveal a good cosmetic emergence profile of soft tissue around the collar of the tooth, not implant. Then smile symmetry. You should give such a processes that bilaterally it should look similar. It should not look like a foreign processes. Incisal edges in relation to lower lip. The ratio of the incisal edge should be parallel to the lower lip line. Amount of gingival display. Gingival display should be like following the golden ratio. TMJ movement. See, if things are fine, everything is fine, but mouth opening is less. How will you carry the implant placement procedure? First tell me. So posterior teeth are missing and mouth opening is not there. You need to rule out reason, whether it is TMJ, whether it is SMF, whether it is anything else. You need to rule out that, and accordingly you need to treat that first. You need a good amount of mouth opening even to begin with the implant surgery. Then intraoral examination. As I told you, jaw opening, instrument कैसे pass करोगे? No, it's not possible. So apt amount of jaw opening, then oral hygiene maintenance. Even in case of natural tooth, people lose natural teeth because of the periodontitis, because of poor oral hygiene maintenance protocols. And that is why those patients who are habitually not maintaining the oral hygiene properly are not the right candidate for implant placement. Then comes any other lesion in the vicinity like abscess, something which affects the overall outcome of the implant. Then the ridge crest or crest of the edentulous area. If it is knife edge, how will you start with the implant? So you need to check. For that, radiographic analysis is not required, but yes, first is clinical one. Then comes the depth of the vestibule. Wherever you are putting implant, make sure the width of attached gingiva is adequate, vestibular depth is adequate. Otherwise, what will happen? If, say you are putting an implant, everything is fine, your procedure, pre-operative, para-operative, post-operative planning, excellent. But at the same time, if it happens that the vestibular depth is inadequate, greater on gingival recession will be there. Then inter-arch relations. How the crown height space, vertical bone loss. If surrounding bone has vertical bone loss, what will you do? It is not possible to have the implant placement over there. Inter-arch distance for posterior teeth is 7 mm, 8 to 10 mm for anterior teeth, and 12 millimeter for restorative processes, I mean removable processes. But beyond that, it is definitely not acceptable. Now, incisor occlusal evaluation. You need to check overjet, overbite, deep bite, adhesion and pattern of tooth wear. Why? Because if overjet, is overjet not sufficient? If there is a cross bite or something like that, overbite is not sufficient, overjet is not sufficient, then your final processes will rest on that faulty occlusion only. And that is why you need to check, evaluate this other teeth symmetry first. If it is deep bite, then they are not good candidates for implant. You need to correct the deep bite with the help of prosthetic intervention. Adhesion, again the bite is collapsed, that is why adhesion needs to be treated first, and pattern of tooth wear you need to check. Now vicinity to vital structure. If you put implant in anterior, posterior, maxilla mandible, there are things which needs to be considered. As far as lower anterior considered, fine, not a problem. Upper anterior, nasal spine, anterior nasal vessels. Posterior, there is a you need to check about the sinus lining. Lower posterior, upper posterior, then lower posterior, you need to check with the vicinity of mental nerve, inferior alveolar nerve, right? So keep one thumb rule that minimum 1 to 2 millimeter should be the distance from the vital structure, except in case of mental foramen, because in mental foramen sometimes the nerve has a loop. After loop it enters the mental foramen. So you need to keep the margin of 5 millimeter in case of nerve. Bone evaluation, जहाँ पे इम्प्लांट रखने वाले हो वो बोन का हाइट, विड्थ, लेंथ, एंगुलेशन and final crown implant ratio, what will be there. Have width, how much width? Let us check. Bone width is checked with vernier calipers. Nowadays CBCT is there, so there is no need. Same way length and height. Crown root ratio, though it is 1:1.5 in anterior and 1:1.35 in posterior, for good implant to survive, minimum crown implant ratio is 1:1. Now bone density. Yes, the implant design, surgical approach, time of healing and type of loading, all factors depend on what is the current density of bone while you place implant. The density has been classified into 5 density types: D1, D2, D3, D4, D5. There is up to D4, but there is D5 also. D1 is the dense cortical bone. It has as good as 1250 HU density, and D5 is less than 150. Fresh extraction bone is having the bone of D5 quality. So D1 to D5 it becomes softer, more compact to less compact and more cancerous. Finally D4 is like cotton wool appearance. So various density, even Lacombe, Zarb and Kalmish both divided the density classification. Then the teeth adjacent to edentulous area or implant is important. If they are mobile, why? If perio condition is there, treat it. Crown root ratio of the adjacent teeth. For example, adjacent teeth has a problem, crown root ratio. Then load bearing of the implant area will be compromised. Then come position of the tooth. If the tooth is not in alignment or may act as a barrier for the occlusal symmetry, then it is also a problem. Dental caries. So basically an endodontic, periodontal and prosthetic evaluation is must before planning of implant. Now selection of implant size. See, remember rule of 1237. 1 mm from buccal plate, 2 mm from the adjacent, 2 mm from the vital structure, 2 to 3 mm from the vital structure, and 7 mm from the adjacent teeth. So for a 4 mm regular platform, 4 mm this is 3.5 mm regular platform implant, you require a space of 3.5 plus 3.5 for implant. Between implant you need minimum 4 mm, so 3.5 plus 3.5 plus 4, that is 7 plus 4, it is 11, and 2 mm from the adjacent tooth, so 2, 13 and 2, 15. So if you want to put 2 implant adjacent to each other in a natural space, you require almost 15 mm to 14 to 15 mm minimum mesio-distal space. Why it is required? See, 1.5 mm crestal bone proximity for proper development of emergence profile of papilla. You require tooth, but between tooth there is a soft tissue, gingiva. And for gingiva, you require proper outcome, contouring. Otherwise, there will be plaque accumulation, there will be peri-implant mucositis, followed by peri-implantitis, followed by bone loss, followed by implant failure. That is why this is also important. Now, proper contact contour, adequate width of soft tissue between the implant, prosthetic component, effective cleaning of processes, and to develop harmonious occlusion. These are the 6 factors for which we need space around the implant. It is not like implant is 4 mm and a process is 4 mm, so adjacently 1 mm left, so 6 mm space is adequate. No. 1.5, 1.5, 4. So minimum is 7 mm is required for one implant. We have already learned this. CHS, also known as crown height space, 7 mm posterior, 7 to 10 mm for anterior, and 12 mm for removable processes. We have already. This is optimum CHS, 8 mm. We have written how 3 mm for soft tissue, 5 mm abutment height, 2 mm for occlusal metal for clearance. So 5 plus 2 plus 3, 7 plus 3 is 10. That is the upper side. But minimum for even 1 mm occlusal clearance and 1 mm soft tissue platform, you require minimum of 7 mm height. If 7 mm optimum CHS is not there, you should not opt for implant, or you should treat the opposite tooth first. Now, periodontal health, very important, most ignored thing. What about the gingival biotype? What about the amount of keratinized tissue and vestibular depth? What about the presence of periodontal disease? What about the symmetry of gingival scalloping and contouring? It is important. Biotype, thick biotype. Thickness of the gingiva matters, because you need to, you can measure it with the CBCT, or techniques are, these are various techniques, visual elevation, evaluation, transgingival probing, ultrasonic devices. Then you need to check keratinized gingiva. Your implant collar should rest in keratinized gingival platform. It is essential. Then comes the occlusal analysis. Please, 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 my request is do not opt for implant if the patient is having severe bruxism, because you are bound to fail. Lateral and protrusive movement you need to check. Now, as how to diagnose. One is visual. The crude method it is called. With the probe, cutting the model or cast and connecting the 2 mm distance dots will give you, the inner side will give you estimation of bone, and outer side overlapping is a soft tissue. Then is the ridge measuring caliper. Okay, ridge measuring caliper. After that, conventional and digital. So radiograph, internal, external, IOPA, RVG, OPG. IOPA are the crude methods. So we should opt for IOPA with the grids, and best RVG, occlusal radiograph. Nowadays RVG is the most trusted. RVGs and OPGs and CBCT. They are the most trusted ones. CBCT is the best one. CT scan, it has lower radiation than CT scan. So CBCT is the best thing. Nowadays CBCT and DentaScan, it is not expensive, less exposure, and high accuracy of measurement is there. And margin of error in CBCT less than 0.1 mm. This is DentaScan. It is a software program which will give you idea in axial, panoramic, and cross sectional, all planes, so you can have idea about it. Treatment planning. The surgeon. Treatment planning, that surgeon, prosthodontist, periodontist, everybody plays a good role. So which option to choose? Factors affecting the choose is amount of bone, jaw relationship, phonetics, and lip support. This is the challenge for anterior teeth. Emergence profile, high smile line, periodontal biotype, and high expectation of the patient. Then comes the processes. FP1, FP2, FP3, RP4, RP5. We have already discussed that where then it is a prosthetic component will be taken by prosthetic counterpart. Diabetes, smoking, osteoporosis, and periodontitis. These are the risk factors. But given a consideration, if they are in control, smoking is reduced and diabetes is controlled. If it is not uncontrolled, then yes, you can always opt for implant placement. Now this is a step-by-step approach of implant. Now you can see the lens drill is entering the bone. Sequential drilling. After that, you need to have the depth, desired depth gauge. Once the length is achieved, after that there is just sequential widening till the desired drill, using the larger diameter every time till the desired drill diameter and length is achieved. After that, the implant is removed from the vial with a sterile condition, and it has been attached to the handpiece, and with the low RPM it is introduced within the bone. And that is how the final drill is done with soft and hard bone, and final implant is placed, cover screw is placed over there. You can check this. This is the opening of the implant. We are taking the implant from the vial, placing the implant using a motor. Once the implant is reached the crestal height, it should reach the crestal height. After that, the cover screw is taken, and after that, this cover screw is taken from the vial, and it has been lifted with the handpiece, and cover screw is placed over the implant, and flap is being closed. And that is how the entire procedure is there. And this is the two-stage approach, where once the implant placement is done, this is the flap. Once trapezoidal flap, with the use of this, the flap is deflected. After that, with the use of drill, the implant is placed. Once the implant is placed, it is closed, and then the secondary surgery is done, which is the time given for osseointegration. Once the osseointegration is over, after that, this is the first stage one. After that, flap is closed. After some time, the flap gets, sometime as in the time for osseointegration, that is around 2 to 3 months. After that, again the flap is open, or directly through the tissue punch, the area is punched over here, or the flap is open. Again the cover screw is removed, and the final abutment is there. The abutment is trimmed, and the final processes and crown will be placed over there. So you can see this is the abutment. Healing abutment is placed. After healing abutment is placed, sutures are taken on this. You remove the healing abutment, put the final abutment, prosthetic abutment, and over the prosthetic abutment there is a formation of crown. So this is a screw retention where the final screw is placed, and finally the processes. So patient wants tooth, and the implant derived tooth is there. So with this, I like to conclude that implant is an essential field of any periodontology, oral surgery, or prosthodontics. So please do learn implant and keep progress. Thank you so much. Thank you.